All right, folks, a quick message before we get started from our sponsors, React Health. React Health, formerly 3B Medical, a leading provider of sleep diagnostic, and respiratory products. Now back to the show.
All right, folks, it's another show, so you know what time it is. Time for some pre-cals. What do we got today?
Hey, we've got Adrian Zacher with us today.
Adrian!
Adrian! Trust me, he's not going to sound like he's from the south side of Philly. Because
not even a little bit.
He might be from the south side of London, though, once we hear his accent. But I met Adrian online. He has a pretty significant LinkedIn presence and is always advocating for patients to be screened for sleep apnea in pharmacy. So I thought that it was something interesting that would, be a little different for us here on the podcast. And I think we're going to have a great time with Adrian today.
Yeah, that definitely sounds interesting. That's screening at the pharmacy is just a very simple thing to do. And I do know that overseas, I went to med school overseas, so I do know that overseas there's the community pharmacies take a huge role, or they play a huge role in the patient's health care and well-being. People typically go to the pharmacy first when they have questions about, hey, I got a cold, what do I need to do? They don't go and see the doctor right away. So I could see that, and why don't we do that here? So it'd be interesting to hear what he has to say.
Yeah, you're right. It's interesting how medicine and sleep is done differently all over the world. I mean, in Canada, the DMEs do the home sleep apnea testing. So you begin to talk about something like this, where pharmacies, doing screening and education. It's definitely different, but that's how medicine is. We're a melting pot when it comes to healthcare as a world, and everyone, their cultures are different, how they approach sleep is different, and it'll be interesting to hear how they figured out how to do something, that's special to pharmacy and there in Britain.
What's interesting to me about the pharmacy approach is that a pharmacy is something that's common to almost everyone,
right.
and it's almost ageless. They're, from infants to, the most elderly of the population here in the U.S. And, so to me, it is the one place that we have an opportunity to look at a patient's existing medical conditions based on the types of medications they're on, and then attribute that to potentially undiagnosed sleep apnea for that patient, and do it on a pretty large scale. So I have my ideas and thoughts about how to deploy a program, but I'm interested to hear how Adrian's is working in the UK.
Great point. And with that being said, let's hear what Adrian has to say then. You guys ready?
Yeah.
All right, on to the show.
Lights out.
Welcome, everyone, once again to another fantastic episode of Sleep Tech Talk, the sleep podcast, bringing a new wavelength to sleep technology. How did you guys like that one?
Great.
Well, with that being said, folks, don't forget to like, subscribe, and share this episode as well as all other episodes with your friends, all sleep techs out there, as well as anybody that's interested in sleep. Now, before we get started, we have a very special guest on today. And Robert, I think you're going to tell us about our guest.
I am. Thank you. Hey, I'm excited. This is our first intercontinental podcast recording today. So we had to adjust time zones in order to make sure that we could pull this off today. But we're excited to have with us today Adrian Zacher, who is the CEO of the British Society of Pharmacy Sleep Services, which is a registered charitable incorporated organization. A registered CIO dedicated to bringing sleep expertise to the coalface that is community pharmacy. Adrian is also newly, I actually just saw the LinkedIn post, I think today, a task force member of an independent advisory group to the All-Party Parliamentary Group for Sleep. Thanks.
That's
for
a mouthful. Well
tongue
done.
twister. Yeah, thanks for the tongue twister, Adrian. And then Adrian also runs snore.com, where he returns peace to your bedroom without you being exploited by the countless charlatans merely interested in selling their pseudo-scientific snore cures. He teaches healthcare professionals how to help their patients stop snoring, sleep, and breathe at the same time. Adrian, welcome to the show.
Thank you, Robert. Thank you for getting your tongue around all those long phrases, and it all gets reduced to acronyms, doesn't it, that blind you otherwise.
Well, if I said it with an accent, it would probably sound a lot better. Something other than a Southern accent.
No, I think we should steer clear of that one. I'm not following that.
Oh, well, welcome to the show. And Adrian, tell us a little bit about yourself and how you got into the world of sleep medicine. And then we really want to spend some time talking about this pharmacy sleep apnea program and how you have been able to make a difference in your part of the world as it relates to identifying patients and getting patients treated who are potential sleep apnea sufferers.
Okay, well, thank you. That was dangerous giving me the mic. You won't get it back now. So I come from a dental sleep medicine background. I made my first oral appliance for a diagnosed patient with sleep apnea who happened to be a submariner years and years ago. And he was being paid to stay awake so that other people could sleep in the sub. That was back in '94. Long story short, was involved in all sorts of custom adjustable devices for snoring and sleep apnea for diagnosed patients, right at the very beginning when oral appliance therapy was in its infancy. So yeah, that did that for a long while, and then I think, well, kind of exhausted my interest in the dental side of it. But then I was always frustrated by when I walked around community pharmacy to see the products that were on sale, and I think I like most people, I just sort of got frustrated about it, and then I kind of took a reflective think, well, these guys, pharmacists, they're not stupid people, but they just don't know any different. And talking with one community pharmacist, he said, well, we're just manufacturer-led. And that made me think, well, actually, sorry, but your manufacturer misled. Oh dear, I've said it. So yeah, so then he's gone on a bit of a journey, and unfortunately Gareth can't be with us today, Gareth Evans. He's at the coalface right now in community pharmacy helping patients. He actually, I'm quoting him or paraphrasing him. Now, to his credit, he now realizes that he just has not been helping patients, and he does now. So that, I think I'll stop there. So shall I carry on, or maybe I should pass the mic? Silence.
Well, Adrian, it's great to have you on our show. As you began to evolve in your role, moving from oral appliance therapy to more of the pharmaceutical side, where was sort of your tipping point? It's always interesting to find where was that transition, that thing that sort of led you to this new journey to where you are today. Can you zero in on that for us?
Okay, so it was about November 2019, just before the pandemic. So I hit the UK, and I was using LinkedIn, and I started sending messages to pharmacists to say, would you be interested in expanding your clinical role with regard to sleep disorders? And it was overwhelmingly positive, the response. I'm used to trying to reach out to dentists, and the hit rate was pretty low. But talking to community pharmacists, I think in business speak, they felt the pain. They had patients coming there and they didn't know how to help them. And they had a problem. Whereas the dentists that I've spoken with, I'm not going to make friends here, am I? But they've got the tools, but they just, I didn't feel that they didn't have patients queuing up saying, help me with my sleep problem. And so the pharmacists were really, really interested in what I had to say. And then, of course, everything stopped for the pandemic. And then, we kicked off again as a group in 2021. And again, the interest has been astonishing, and we're only just a year old now as a charity, and it's going really well. And I'm very positive and optimistic, and that kind of brings me to here and having your ears. Thank you very much.
Certainly happy to have you. One of the things that I worked for Philips for several years, and it was interesting how sleep medicine is treated around the world. In some parts of the world, Asia, sleep disorder breathing seem very different than it is in, Europe and the Americas. When you look at Europe, though, one of the things that I noticed was a really strong emphasis on trying to look for CPAP alternatives that more than we see in the United States. So is that the same in Britain with what you see? Is there a strong emphasis on non-CPAP or at least alternatives to CPAPs relative to what we see in the States?
Well, I think it depends on which medical or dental professional you talk to. So I think the medical professionals, I mean, it's silos. Come on, let's be honest, it's silos. If you're talking to medical professionals, it's CPAP or CPAP. And the CPAP is funded, and CPAP is easy. It comes out the box. You just dial up the pressure until you get a result. Oral appliance therapy, well, the dentists are going to bang the drum, but dentists and pharmacists are like opposing football teams. It's kind of just, you're really struggling there. There's no, it's always ruled out the joint clinic on expense grounds. We can't have everybody in the same room. It's too expensive. It might be sensible and we might resolve it more rapidly, but it's too expensive. Then ENT, well, I think it's, and oromaxillofacial surgery. That's really where I became interested in the max fac side of things. Wow, I don't know. It's the last resort, isn't it? The tracheotomy or the bimax osteotomy. It's the last resort. But it's always, an ENT seems to, when it fails, okay, let's try an oral appliance. Well, hang on a minute. Let's just try an oral appliance first. Then maybe we don't need to do the general anesthetic and the 8 hours in surgery. And, it's just, there's no joined up thing. But I don't know. And come back to answering your question, I think that there are routes to care, and I've advocated a dental route to care for a long time. Empowering the dentist to screen and recognize those patients that are not going to merit treatment with CPAP because they're not severe enough that, frankly, and they won't derive a benefit from CPAP, so they won't persist with CPAP. Those patients really need an oral appliance, a custom adjustable device. That's to me, it's logical to use the dentist to filter referrals into secondary care, and then the patient's in the right place if they are not appropriate for CPAP. So use the dentist. That, to me, I'm kind of, perhaps I'm naive, but it just seems that we have a network of dentists that exist, far more of them than we have sleep units and that expertise, and it's a triangle. And then carrying it that step further, that's where we bring in community pharmacy. We have lots and lots of pharmacies. So anyway, maybe I'm silly, but that's just, I just want to get out of these silos and look at it from a bigger picture.
So Adrian, you struck upon a point just now about the community pharmacies. Could you elaborate a little bit on that, on the role? Because the role of the pharmacy is a little different here in the United States. So we'd love to hear a little bit more about that.
Hey, Jerry, before you answer, Adrian, can I add to that? And I'm interested as to what your approach is. Is it sort of a population health approach where you look at certain types of medications that might, be a condition that typically would be a high prevalence of obstructive sleep apnea? Or is it just as simple as, we implement a stop bang for patients who walk into the doors of the pharmacy?
Oh, wow. Okay. So, right. Well, we're trying to kick off a pilot project, which we've called the Early Intervention Community Sleep Support, a pilot. So EICSS, another acronym. But the idea is that we take the patient on an evidence-based journey. So we're not just going to throw a stop bang or an ESS at them. We're going to use a clinical decision support system. First of all, so we're going to do both insomnia and OSA, because those are the two big ones that we've found that the prevalence. Insomnia is probably eclipsing it just slightly, OSA, but there's not really. We're quite pragmatic here. We look at it as there's little point in worrying about your head if you can't breathe. So let's try and deal with the patient's ability to breathe, before we try and get their head straight with their insomnia. I mean, brutal. As I say, I'm not a doctor. So we're going to take the patients through a clinical decision support system that is based upon a pre-treatment screening protocol that an eminent professor, John Stradling, and Dr. Roy Ducombe put together as part of the British Society of Dental Sleep Medicine. And as I say, that empowers the dentist, or effectively any healthcare professional, to assess, screen, and recognize symptoms of obstructive sleep apnea, relevant comorbidities, and then pretty much using that as a filter to actually identify those patients that do absolutely need a home sleep apnea test and those that don't. Does that answer you, Robert? Then we go into further questionnaires depending upon whether it's insomnia symptoms that are prevalent. We might do a home sleep apnea test if to firm things up. I don't want to give away all the secrets of our pathway.
So I see it as, for those pharmacies that would do proactive outreach. I also see marketing campaigns that could be done to certain patient populations that would tie diabetes to obstructive sleep apnea.
Absolutely.
You know what I mean? Yeah,
I do. Right. So, we're definitely looking at the relationship with type 2 diabetes and obesity, cardiovascular, the big life or metabolic syndrome. That's what we're looking at. They're definitely looking at those. And within the UK, there are pharmacists that specialize in weight management. And so it's easily transferable. And the weight management pharmacists I've spoken to, when they become aware of how they can actually help a patient, and it's an easier conversation. They can talk to someone about, oh, do you snore? Or the partner says, oh yeah, they snore. Well, I can help you with your snoring, which is what they might present with, by losing weight. So it's an easier conversation for them. So rather than, you're a bit large, I can help you. That's not a nice conversation, is it?
Well, I know that, when you look at a patient who has drug-resistant hypertension, at some point, someone has to ask that patient, do you snore?
Yeah.
Right?
Yeah. Yeah. Well, it's an easier conversation and perhaps a little more palatable. And we laugh about it to cover our embarrassment, but it's definitely an easier conversation than weight management, initiating that conversation. That's, so they have the expertise, they're set up for it. I've talked to pharmacists with that expertise, and they've helped people with dramatic weight loss. They have pre and post weight loss home sleep apnea test results that objectively validate how they've eliminated OSA. So it's a powerful tool. Obviously, it's a case of whether they can sustain that weight loss, but we've got to take it as a bigger, wider, holistic issue. We've got to get out of these silos of sleep apnea. Oh no, I'm in the diabetes field. Oh no, I'm in the the hypertension field or heart failure. Metabolic disease hits us in multiple different directions, so we need to respond in that way.
Adrian, your model is extremely fascinating, unique. Do you have, if you could point back to a particular case or experience that you had, is there one of those that's always motivating to you, that was gratifying and very rewarding to identify one in particular where your model made such a difference in someone's life?
Okay, I'm going to throw one in from dental first of all, and that was a fabulous case. A quadriplegic lady and we used an oral appliance. So I was quite negative about dentists, first of all, and oral appliances, but I'm going to try and rectify that now, pull it back. So quadriplegic lady, AHI 60s, and we made I'm not going to put the name of the brand of the device because that would be terrible, but no. So a custom adjustable prescription device. And you've got to bear in mind, this lady could not put the device in her mouth. She, and when she had the oral appliance in her mouth, or sorry, when she had CPAP on, she could move her head around and she would displace the mask, but she didn't have hands in the middle of the night to readjust it, So it's you've got to really picture it. And of course, when she had the CPAP on, she was deprived of the ability to communicate because she had like a pointer or a pencil in her mouth. So she had the choice of communicating or wearing an ill-fitting CPAP mask. It was really tough. So we made an oral appliance, and it took her, it was deemed it wasn't a success. Technically, it wasn't a success because her AHI went from 60 to 6. Come on, 6. That's not a success. Well, what is, And she thought it was fabulous. She could still communicate. She could still hold the device between her lips and still communicate whilst wearing the device. And she felt transformed, so much better in every day. Anyway, so that was that. So in the community pharmacy field, I'm deprived at this point really of that patient feedback in large part. So it's sort of second hand. And I wish Gareth was here because I've had him on the phone, pumped, absolutely enthused, and he's helped people, and they've been fast tracked on the back of the quality work that he's done. They've gone into again, I won't put a name on it, a hospital, a sleep unit in the UK, and instead of the year-long wait, they've been in 3 months because he's identified a real need, and it's still 3 months, but it's a whole lot less. So,
Adrian, one question: the pharmacies that you educate about screening for sleep apnea and who develop a program, do they actually conduct the sleep testing, or is it a referral to a diagnostic provider? I don't know the healthcare system well enough in your area.
It's a private service. So so community pharmacy in the UK, they're both NHS. It's a blended revenue. I think that's the phrase. So they are NHS funded, but they're being, like everywhere, they're being squeezed financially and, shall we say, incentivized to develop private services. Now, sleep apnea screening is a private service. This is something that they would charge the patient out of pocket, a minimal fee, and they'll take the patient through a CDSS, clinical decision support system. And on the back of that, if it's appropriate, they can do a home sleep apnea test. Now, the interpretation of the data is absolutely down to a sleep tech. That's why we're here. But it's the opportunity to get the patient right there. That's the cold face. It's not somewhere further down the line. How many patients have fallen off the pathway? If we can get them on that first interaction and make it an informed conversation, yeah, that's it. So it's a private answer. It's a private option. That's my answer.
Everybody's waiting for Jerry to cut us off. I just assumed.
No, you're right. We are getting close for time. Thanks, Robert. So Adrian, we definitely are up for time. Is there anything that you want to add that we haven't really touched on today? I mean, obviously everything is really fascinating, and I love the community approach. I was just thinking back to my days in med school about preventive and social medicine, and that's what it sounds like you're attempting to do. But is there anything that we haven't touched on today that you'd love to talk about?
I'm going to put a guy's name into Miquel Azpiazu. Was in northern Spain. I just called up with him a couple of months ago. He's a physician, sleep physician, and he said to me that there are more pharmacies in his region of northern Spain than anywhere else in Europe. I don't know if he said the world, but if you think about it, healthcare professionals on the high street that you can actually go and have a conversation with, at least here. I mean, you might have to wait 5 minutes, but it's a drop in. And these guys are smart. The opportunity to fundamentally change healthcare and sleep disorders, assessment, screening, recognition, the whole thing exists, and pharmacies are everywhere. So there it is. I hope everyone jumps on board with it. Got to try.
Well, thank you, Adrian. It definitely is very inspiring. And yes, we all do hope that everybody jumps on board with it. That's something that we strive to do here in the United States as well. And we do have a small international audience, and I'm sure they would all agree to be in the same manner. Wow. But we are out of time.
Hey, Jerry, by the way, Adrian, before we run out completely out of time, he has developed his own hashtag that I think is pretty cool. Adrian, can you tell the audience what that is?
Okay, so it's snore, yawn, warn. So snoring, yawning, well, it's a warning. So, it's snoring is not always benign. I think that's probably the message.
I love it.
Snore, yawn, warn. All in one.
Snore, yawn, warn. All
there
right.
There you go. So,
all right. That itself is a tongue twister too. Along with all the other
acronyms.
And exactly. So snore, yawn, warn.
There you go.
Try to say that 6 times quickly. So
more whiskey.
There.
Yeah,
hey, it is like we say here in the States, it is 5 o'clock somewhere. So we're looking forward to that. Maybe Adrian, someday we're going to be able to share a dram together.
I look forward to that very much. And I just want to say thank you very much for hearing me. And I'm banging the drum for community pharmacy. So thank you very much.
Thank you, Adrian. And thank you, all of you out there, our listeners or viewers. Thank you so much for joining us once again. And we thank you for all the likes that you've given us, all the love you've shown us. And looks like Robert just jumped off. But hey, maybe with your likes and your love, you're going to be able to bring him back. But don't forget to like, don't forget to subscribe. Most importantly, do not forget to share. We're growing, and that's only because of you. So thank you so much, everybody. Until next time, cheers.
Lights on.
All right, folks, a quick message from our sponsors, React Health. React Health, formerly 3B Medical, a leading provider of sleep diagnostic, and respiratory products. Now back to the show.
All right. Robert made it back, so that means it's time for some post-count. Oh, yeah. Man. Yeah.
Hey, listen, I have to rely on Elon Musk to send me internet over here in the outermost part of North Carolina. So some days it's better than others.
Appalachian internet, baby.
That's right.
I remember when I think it was during the lockdown in 2020, and things would be running really slow because the kids were playing their games or whatever, and I'd start screaming at them, "You used up all the internet!" And they're like, "You could that's not even a thing."
Oh yes, it is.
Oh, it's a thing. Yeah.
Yeah.
It's like, leave it to me to figure out new things. So
right.
But let's get back to it. What did you think? What did you guys think about today's show? Our guest today.
Adrian was interesting. No, we talked about this in our pre-calls, how healthcare is so different around the world, and it's so unique to hear how pharmacy is doing something different in the UK. It sounds a lot like sleep navigation here. What we're seeing with the CCSH, with the sleep educator and that role. And so it's really interesting that we would hear pharmacy stepping into a place where we see sleep technology doing that here.
That's a really good point. I never looked at it that way when he was talking, but then again, I'm not as smart as you guys. So I'm just here for the looks made for a podcast. But anyway, I do agree. There is a huge correlation there between what he's talking about, screening at the pharmacy level versus a sleep navigator program, which we talk about over and over and over again. I think the key here is the grassroots level of getting to the patient. These patients are underserved when it comes to sleep disorders, and we talked about the correlation between diabetes, hypertension, and he spoke about cardiovascular in general. But we talk about as sleep professionals the correlation between diabetes, hypertension, stroke, and a multitude of other things. And that's simply by that initial screening, we can tackle all of these problems through a diagnosis of sleep disorder. At least that's what I see.
Absolutely.
Robert, you're pondering something.
Well, just, this is something I've actually had as a concept of a potential opportunity, patient acquisition opportunity here in the U.S., thinking about how our healthcare system works and thinking about the commercial payer side versus the private cash paid type of patient, and utilizing, he talked about the community pharmacy, but I think that where there is a potential opportunity here in the U.S. is the independent pharmacy. There are some of the nationals, the Walgreens and the CVS's. I know CVS has had some fairly significant approach to screening patients for OSA as part of their health hub. But I think the independent pharmacy and some of the independent pharmacy networks that are out there is a place that is it's really fertile soil for us in the sleep medicine industry to go out and to, approach these independent pharmacies that are looking for something that is a differentiator for them and potentially even a new business and new service that they can provide to their patient. Think about the patient who is that drug-resistant hypertensive patient who has tried multiple types of medications to overcome their hypertension, but they're going home every single night with undiagnosed sleep apnea. And it's certainly not going to cure their hypertension, but it absolutely would make them a more healthier patient from a cardiovascular standpoint. So there is a there. I'm just wondering, how do we get here in the U.S., who is the person, what's the entity that gets pharmacies engaged and involved in looking at patients for untreated sleep apnea?
It's interesting. I can hear some people saying, well, that's my job as a sleep tech. That's what we do. But, as long as the three of us have been doing this in sleep, one statistic has been very constant, that 90% are undiagnosed and untreated. Right. And that number doesn't seem to be changing, which is really phenomenal, because you would think we've at least break into the 80s at some point. Right. But we're not. So, to your point, there's an access problem, and the interesting thing that I think you just pointed out is that those pharmacists do see that they have refractory hypertension. They do see these comorbid things lining up with the patient coming in to get all these meds filled up. Could there be a flag in the system that becomes an identifier that says, this person needs to have this questionnaire, whether it's a Stop, Bang, a Berlin, an Epworth, but something that really, stops the hamster wheel and makes that person have that check, get at least that evaluation they can carry back to their physician and have that next level conversation about, where they could take their healthcare.
Yeah, I know that in some pharmacies, they have programs where they will sort of go through their patient population and ensure that there are not conflicting medications that a patient might have been prescribed by different physicians. So, why not do that same, type of initiative, but ensure that there's not conflicting medical conditions that might be exacerbating a problem that they are, the patient's receiving prescribed medications for.
Well said, because Adrian spoke about this quite a bit, which was being siloed. This is siloed, that's siloed. And we know healthcare here in the United States is extremely siloed. I may be treated for a heart condition, but they never look at the fact that I have obstructive sleep apnea that's causing that, whether it's AFib or hypertension or whatever. Nobody seems to look at that. And yeah, just being able to put these pieces together at the level of the pharmacy, that would be a great idea. Hey,
we must have lots of hamster wheels spinning between the three of us today, because this might be the most serious conveation we've had on the show in a while.
So we have to stop it while we're ahead.
There's something here.
Mic drop.
Exactly. For those of you listening out there, just want to let you know, Adrian was very impressed with our backgrounds today and our outfits. And I told him, We all were saying that this is probably the most professional that we can ever get. But hey, today's topic was also a little more professional than usual. So
we rose to the moment. We rose to the moment.
Exactly. All right, then. With that being said, folks, thank you all for hanging out with us till the end, and stay tuned until the next episode. Until then, cheers. See you all next time.